Good afternoon, everyone. And at the very outset, my sincere thanks to ISG, Professor Govind Makaria, Professor Saraswat, for giving me this opportunity, number one. And secondly, I think I must compliment them and for this wonderful initiative which they have taken. I think they deserve our congratulations on this. Wonderful idea. So the job, I know we are all passing through a difficult time, but the job I have been assigned today is to talk about non-alcoholic fatty liver disease, current and the emerging treatment. So before I go on to the, the treatment part of the fatty liver disease, I think I'll just take you through a little bit of maybe epidemiology. And then I think we will discuss first the, the current treatment and then followed by the emerging modalities. When we talk about NAFLD or NAFLD or non-alcoholic fatty liver disease, we understand that this is a kind of spectrum. You can have just fat in the liver, which is known as NAFL or non-alcoholic fatty liver, or earlier people used to call it as simple steatosis. We also know that some patients with fatty liver alone can progress on to what we call NASH, which is a severe form of fatty liver disease where you have, in addition to alone fat, you can have inflammation with or without fibrosis. And if you have NASH, you have a higher propensity to progress on to cirrhosis. And once you have cirrhosis, obviously you can have all the complications of cirrhosis, including HCC. But then we also need to understand at this point that when we talk about NAFLD, the most common cause of death in patients with fatty liver disease is not liver disease. It's the cardiovascular disease and the malignancies, which means it is because of the kind of milieu these patients have. They are more prone to, the cardiovascular disease and the malignancies, and the liver disease comes as the third most common cause of death in patients with fatty liver disease. Few years back, I think we started thinking about that. How about those patients, those who have non-alcoholic fatty liver disease, but do take alcohol? And similarly, how about those patients, those who take alcohol in significant amount, but also have metabolic syndrome, like, for example, they are obese, diabetic. So based on that, I think a lot of, people started thinking that can you have a combination of these two diseases? And for the residents, I think the first message I would like to give is the changing nomenclature, which is happening in the area of NAFLD. And this was the commentary, which was published late last year, where they have divided the fatty liver disease into two major headings. One is the metabolic predominant fatty liver and the alcohol predominant fatty liver. And within the metabolic predominant fatty liver, you can have subgroup of patients who are taking alcohol, and within the alcoholic predominant fatty liver, you have some patients, those who have metabolic risk factors. So this is the change which is happening in the nomenclature. And I would also like to attract attention of the residents to this very recent paper, which is a pre-proof in the Journal of Hepatology, where this group actually has, this international group has given what we call the consensus statement about the new definition of, they are calling it as a metabolic associated fatty liver disease, or MAFL. The time doesn't permit me to get into the details of this paper, but you need to know this in detail. And this paper also gives you about the definitions of how do you basically classify or define NASH-related cirrhosis and NASH-related HCC and so on. I think over the years, I think when I've been taking the lectures and talks and speaking to the residents, I've got into the habit of, asking questions. But now this is the forum like this where you can't ask questions. So I have written it for myself, and I will have to ask questions and give answers simultaneously. So the first question, as I said, I need to know the epidemiology, that what is the the prevalence of fatty liver disease. I think over the years, I think, and again, the residents need to know, I would say, 3 studies. The first study is this by Zubair Younusi. This is a meta-analytic study where they looked at all over the globe. And if you look at overall prevalence of fatty liver disease globally was given as around 25%. And highest, if you look at it, is in the Middle East and in the South America. But Asia also is not far behind. This is around 27%. Similarly, you also need to know this recent meta-analysis which was published last year in Lancet Gastroenterology and Hepatology. And this was in Asia. And again, if you look at the prevalence of fatty liver in Asia is again close to 29%, which is, a big number. Also, I would suggest residents to know about all these Indian studies from all parts of our country, the west, east, south, and north. And look at this, the figures are variable from maybe 8%, which is from the rural part of Bengal, to as high as 53%, which is at Chandigarh, we found in the blood journals. Also, I think for the residents, if you look at the earlier studies from this country, a lot of us actually published this work, I'm sorry, and said that the fatty liver disease in India is kind of mild, which means that we do not have many patients with so-called progressive NASH. We do not have patients with so-called high fibrosis, but again, things are changing as the data is developing. And I must again say that the residents must look at this particular study from ILBS, where they had published 3 years back data on 1,000 patients of biopsy-proven fatty liver disease. And if you look at this, the NAFLD activity score, which defines NASH, definite NASH by a score of 5 or more, 61% of people had NASH as defined by the NAS. Similarly, if you look at the fibrosis score, I think a reasonably high number, maybe close to around 65% people had significant fibrosis, which means F2 or more. Excuse me. Okay. And also, I think this is our recent, presentation at the APDW, which we made in the plenary session. This is the ongoing study, which we call it as the Indian Consortium on Non-Alcoholic Fatty Liver Disease, ICON-D. And we presented there the preliminary data of more than 2,000 patients. And if you look at that, of the data which was available of ALT in around 1,800 patients, around 45% of them actually had raised ALT. And if you look at the significant fibrosis, which was based on a fibroscan in around 1,300 patients, the significant fibrosis, which was defined as the LSM value of 8 or more, was seen in around 40%, and 12% of them already had cirrhosis. So this actually gives us the quantum of, the liver disease, which obviously we are facing in this country, in Asia, and globally, I think, which you all need to be aware. Now let me come down to first what I said, the standard of care today for fatty liver disease, and then, as I said, we will go on to the emerging treatment. And for this, again, I would like the residents to go through this our position paper, which was given by our 3-4 societies, the INASL, the Endocrine Society, the Cardiology Society, and the ISG. But now this is getting a little older, but I think the concepts almost remain the same. This was in 2015. So what we suggested is that whenever you have a patient with fatty liver disease, NAFLD, obviously you need to exclude alcohol. You look at the components of metabolic syndrome. I think first step is that you must try to classify patients with NAFLD into whether they have, as I said in the beginning, NAFL, or they have NASH, or they have cirrhosis, or they have HCC. So there are certain ways of doing that. And usually we take the help of various non-invasive tests or markers, and then they will help you in basically assessing whether they have NAFL or NASH or cirrhosis. Why this is important is because the natural history or the prognosis is entirely different in those who have NAFL versus those who have NASH. because of the outcomes, because of the mortality. Again, there are lots of studies which have shown that patients with NASH, they are more likely to have poorer outcome in comparison to those who have NAFL. It doesn't mean that the NAFL cannot progress. There are again studies now showing that the NAFL also can progress. Now, how do you differentiate between the two? Age is a very important, marker, right? As the age advances, your chances of having severe fatty liver disease actually go up. And I keep saying this in most of our meetings, that a 20 years boy with a fatty liver disease is entirely different from a 55, 60 years old lady postmenopausal with fatty liver disease. That postmenopausal lady could very well be having high fibrosis or cirrhosis, and that young boy could just have what, as I said, NAFL. So other than the age, as I said, the gender is important, which, as I said, mainly the postmenopausal ladies. You look at the AST-ALT ratio. APRI, I think you all know this is the AST platelet ratio index, very helpful bedside test. You can just look at the AST platelet, calculate this. But the most important, which is also applicable at the peripheral level or at the primary healthcare level or even at the secondary healthcare level, is that you just look at the components of metabolic syndrome. So, the diabetes, obese people, dyslipidemic, hypertensive, I think we all know the components of metabolic syndrome. They are more likely to have what we call severe disease, which is NASH or high fibrosis. Very, very important. CK18 is a marker of, apoptosis. Unfortunately, it's not that freely available, but this is a score, the FIB-4 score and the NAFLD fibrosis score, what we call NFS, are free online calculators which you can very well use in your daily practice and try to characterize or try to prioritize or try to classify your patients into NAFL or NASH. And lastly, but not the least, I think most of our centers are now equipped with what we call the transient elastography, or for that matter, any form of elastography. And if you have high LSM, as I said, we defined in our study, and most of the studies have done it, that if you have LSM of 8 or more, I think you tend to have what we call the fibrotic NASH, or this is a significant fibrosis. And depending upon this, if you have all these risk factors, this actually becomes an indication that you may have to do a liver biopsy in your particular patient to confirm that he has NASH with or without fibrosis. So that brings us to the next question, which is very important again for residents. And I keep asking them day in, day out, that what are the indications of liver biopsy in a patient with fatty liver disease? So first and foremost, as I said, is that if you have risk of having steatohepatitis, which is NASH or advanced fibrosis, based on your non-invasive assessment, and these are the ASLD recommendations, that if you have metabolic syndrome, if your NFS is high, FIB-4 is high, or if your stiffness is high on transient elastography, or if for that matter, even in MR elastography, I think these patients are at a higher risk of having NASH and advanced fibrosis, and we can subject these patients to liver biopsy. And the other indication, 2 indications for liver biopsy, is that if you are not able to exclude any what we call the competing etiology for liver disease or fatty liver or raised transaminases, it could be Hep B, Hep C, autoimmune, Wilsonian. I think there's so many causes which can cause fatty liver, which can cause rise in transaminases. And if you have any of these confounders, I think in clinical practice, we always tend to do liver biopsy in them. And last, which is also important, is that as a part of clinical trials, those who and we know that various drugs are under clinical trials, and most often they would take it as a baseline liver biopsy and maybe biopsy at the end of the clinical trial to, basically look at the treatment outcome. Okay, let me now move on to, after the diagnosis and all, to the, how do we manage, as I said, in the current scenario. So once you have a patient with fatty liver disease, as I said, you looked at the metabolic risk factors. The first and foremost is that you must always try to control these metabolic risk factors, right? So if they are there, if they are not there, obviously, I think we'll come down to that later. So if somebody is diabetic, hypertensive, dyslipidemic, I think there are various drugs which are recommended in these patients, and we must control these risk factors. Very, very important. Those who are overweight or obese, I think weight reduction is very, very important. How much, how to do that, I think how far can we achieve that? I'll come down to that in a little while. But the point I would like to stress here is there's an entity called, which came from our country initially when we were using the international criteria for overweight and obesity, so-called the lean effort or lean NASH. These are the people, those who have fatty liver, but do not have so-called overweight or obesity, and they may not have even any other metabolic risk factors. So these are the groups, they come here without metabolic risk factors. So even in them and here, the one thing which is recommended in all patients with fatty liver disease is irrespective is the regular exercise. So now what kind of exercise, as I said, how long, I'll come down to that, because exercise has been shown to improve the insulin sensitivity, which is the major pathogenic mechanism in patients with fatty liver disease. So exercise for everybody here, whether they have metabolic risk factors or they don't have metabolic risk factors, or they have metabolic risk factors, they have to do it. Okay, now what kind of exercise? I think usually we tend to ask them for what we call the aerobic exercises. So aerobic exercises means that it is the brisk walking, jogging, swimming, cycling. These kind of exercises are usually recommended. But though we now also have data on what we call the resistance exercises, and these days during the lockdown period, when I think it may not be possible to go into the gyms or to the parks for the jogging and walking, I think the resistance exercises or the exercises which you can do at home are also beneficial in patients with fatty liver disease. If you're doing aerobic exercises, the recommendations are you should do at least every day. If not every day, at least 5 days a week, and 1 hour, and if not 1 hour, maybe 30 to 45 minutes in one session. The idea is that you should be able to reach around 60 to 70% of your maximal heart rate. Now, how do you calculate your maximal heart rate? Is basically, it's a very simple formula. You just say 220 minus your age, and that figure you achieve. I think, so if somebody is, say, 100 years old, I'm saying that, or somebody 60 years old, so 220 minus 60 would be 160, and 60% of that, if you're able to achieve, is what we call the maximal heart rate. And more simpler way is that if you're carrying your mobile with you during, if you go for a jogging or walking, you should not be able to speak on your phone while you are taking a walk or a brisk walk. That kind of, I think, brisk walk which is required, which should increase your heart rate, which should feel you sweating, and I think that is the aim. So overall, and with this kind of, this thing, the other important aspect is the dietary component, which is very, very important. And the dietary component is that you have to cut down. I think we all understand when we look at the pathogenesis of fatty liver disease, there are 3 things which are important and which contribute to the fatty liver disease. One is the insulin resistance, as I said, and that insulin resistance basically causes the increased lipolysis from the adipose tissue, and there is increased delivery of free fatty acids into the liver, right? So that's the major mechanism. But the other 2 mechanisms are, one is the de novo lipogenesis, which happens in the liver, and the third is your dietary calorie intake. That's very, very important. So you have to cut down on your calories. And when we say cut down on your calories, and there's a lot of data now available that it's not only the fat reduction, it's the reduction of both fats and carbohydrates, which are very, very important. And then we take, the next question is how much reduction? So in journal or in clinical practice, what we tell our patients is that you have to reduce your calories by 30%. The simple, way of telling your patients would be that if somebody is taking, say, 3 chapatis in one session, ask him to come down to 2. So 1/3 calories are kind of cut. So the calories are cut, you are exercising more, you are trying to creating what we call a negative balance. So negative balance means that you are burning more calories, you are taking less calories, and you're trying to achieve what, as I said, weight reduction. And the weight reduction, what is recommended is, I'll come down to that. In clinical practice, we give them a target of 10% over a period of 6 months. But then depending upon, as I said, which stage the fatty liver comes to you, you can advise them weight reduction. And there's a very good data which is available on this. I think residents should know that the weight reduction which is recommended if somebody is only an NFL and is overweight or obese, maybe 3% weight reduction or 3 to 5% is good enough. But if you're looking for the inflammation part or NASH resolution, then maybe 5 to 7% weight reduction is very important. And if you're looking for the fibrosis reduction, then maybe more than 10% or up to 10% weight reduction is very, very important. Having said that, now what we need to see is that these lifestyle interventions, which are so important and they are so helpful and they are so effective, are they really possible, and what are the challenges, and are these practical? So there are some problems with lifestyle interventions. One is that, as I said, all patients are not obese. So there's a group of what we call the lean NASH. What do you tell them? So obviously you can't tell them for weight reduction. So you basically just tell them for exercise, as I said, and improve their insulin sensitivity. The study which I showed you, the pyramid which I showed you about the 5% weight reduction and the 10% weight reduction, if you look at that data, the 5% weight loss was achieved only in 1/3. Which means even if you give target to these people or these patients, only 1/3 of them are actually able to achieve 5% of the body weight. And if you talk about 10% weight reduction, only 10% of the people are able to reduce their 10% of body weight. I think, so that is the problem. So one is that it is not achievable in most of the people, I would say. The second is they are not able to sustain, because there's something known as weight recidivism, which means that you tend to lose weight, but then over a period of time, if you tend to relax, I think you tend to regain weight. This is known as weight recidivism. There are certain pharmacological interventions for weight reduction, but they are not recommended for fatty liver disease. So I'm not going into the details. So if there are problems with the lifestyle interventions, do we have other interventions to help us out in weight reduction? Yes, I think you know. One of them is a surgical modality, the bariatric surgery, and lots of kinds of bariatric surgery, especially the sleeve gastrectomy. But the problem with bariatric surgery is that it is effective in reduction of fat, NASH, but then there are no randomized controlled trials on bariatric surgery. We have a lot of cohort studies which have shown that pre and post bariatric surgery, people's the severity of fatty liver disease actually have come down. But then because of the absence of randomized controlled trials, it is still not recommended as a treatment modality for patients with NASH. But yes, if it is otherwise indicated in an obese person, I think you can very well do that, and you will find reduction in the severity of fatty liver disease. Now, the question again is that how many persons or how many patients actually can be subjected to bariatric surgery? And again, there's a good data available from the bariatric societies, and where they have shown that all those who qualify for undergo bariatric surgery, which means their BMI is, say, some people take it as 35 cutoff or 40 cutoff or whatever you have with different societies, only less than 1% of the people ultimately are subjected to bariatric surgery, which is a very, minute number, number one. Then there's a problem of, the cost of the surgery, preference of the surgery, accessibility, and mind it, the surgical intervention is not free of morbidity and even mortality. So I think this is a high-end effective, high-end treatment for obesity. And as I said, not recommended for patients with NASH because of the absence of randomized controlled trials. The next is the lesser, which is the lesser, invasive, is what we call the endoscopic and bariatric metabolic therapy, or EBMT, which is less invasive. But then the problem is, again, we have a very limited data again on this. Various kinds of endoscopic bariatric modalities are now coming up. But again, there are no randomized controlled trials. And again, it is still not recommended for patients with NASH. But I would also like to draw attention of the residents to this recent study, which was presented in ASLD in November 2019, which actually use this DMR, or DMR is basically duodenal mucosal resurfacing, which is, the endoscopic mucosal ablative procedure. And they had patients with type 2 diabetes with fatty liver disease. And what they showed after the procedure, that there was a definite, over a sham, there was a definite superiority of DMR, or duodenal mucosal resurfacing, in reduction of the liver fat, by which they assessed by MRI PDFF, and in their glycemic control by the HbA1c reduction in patients with type 2 diabetes. But then, as I said, the data is very limited, and I think we would expect more studies on endoscopic modalities before we accept them as modalities for treatment of NASH. Now we come to the current pharmacotherapy for patients with NAFLD or NASH. I think the pharmacotherapy which are recommended by most of the societies, including the INASL and the ISG, are these two drugs. One is the pioglitazone and other is the vitamin B. But then, as I said, these data is now getting old. This was actually based on, and this is recommended usually in biopsy-proven NASH. And this was based on the landmark study by Professor Sanyal, which is known as the PIVEN study, where they compared the pioglitazone with vitamin E and placebo in patients with NASH. Large number of patients, more than 200 and more than 115, I think, each arm. And they showed that both pioglitazone and vitamin E were effective in NASH resolution and without worsening of fibrosis. So I think these are the two drugs which are recommended. But then there are problems with, with pioglitazone and vitamin E. And the problem is, as I said, both these drugs are recommended in patients, those who are biopsy-proven NASH, number one. The PIVEN study was done in patients, those who are non-diabetic. So it is recommended only in non-diabetic, though we do have data of using both these molecules in diabetic patients also. And I think other studies have recommended that you can use them even in diabetic patients also. They are not recommended in cirrhosis, but I would like to show you some data in cirrhotics. The pioglitazone also has a lot of issues like weight gain, pedal edema, and cardiac issues. And there is a theoretical risk of carcinoma urinary bladder with pioglitazone. With vitamin E, again, there is some risk of carcinoma prostate. And there was initially data which had shown increase in all-cause mortality with vitamin E, but then that was later, refuted by the other studies. So this is the data I wanted to show, that the vitamin E, though recommended in non-cirrhotics and in non-diabetics, but this is a recent, retrospective analysis by Nagachala Sani's group from Indiana University, US, and where they looked at around 236 patients with biopsy-proven NASH and bridging fibrosis or cirrhosis, which means high fibrosis or cirrhosis. And they had, two groups, controls and the vitamin E users, and they had a longer follow-up here. And if you look at this, vitamin E users, they had a higher transplant-free survival and lower rate of hepatic decompensation in comparison to the control group. And this was both in the group with and without diabetes. And so I think there is a rational, I would say, in clinical practice, that I think even if somebody is a cirrhotic and if you are short of drugs, I think vitamin E, based on this retrospective analysis, could be a choice. But then, as I said, we would probably need more data in high fibrosis or cirrhosis, which was an exclusion criteria in the PIVEN study. Okay, as I said, pioglitazone and vitamin E. So what more? I think at this stage, I would have asked residents, what next is the standard of care in pharmacotherapy? But I know I can't get answers, so I have to give the answer. So new molecule which has been added onto the list is what we call the saroglitazar. Now, the saroglitazar is a recently approved drug by DCGI in India for patients with NASH, again, without cirrhosis. And this is, we know, is a PPAR alpha and a gamma agonist. And before I show you data on saroglitazar, I think for the residents, it's maybe important to slightly understand about the pathobiology of these nuclear receptors and the transcription factors, which are very, very important. And then you would actually better understand the role of these PPAR agonists. And when I come down to the FXR agonists, I think it will be easier for you to understand. So I think when we look at the pathobiology, I think the important is we need to understand that as human beings, all our cells or tissues would actually require glucose or fatty acids as an energy source. We know that. And there are certain tissues or cells which would depend totally on glucose because they don't have any oxidative capacity, like, for example, erythrocytes and retinal cells and all. Brain also depends on, glucose because fatty acids do not cross the blood-brain barrier. So, this glucose and fatty acids are so important for us, right? So how do we get these glucose and fatty acids? Obviously, I think from our diet. But then whenever there's an elementary glucose shortage, which means that there's a problem, you're fasting or whatever, I think there's a mobilization of the hepatic glycogen by a process, what we call the glycogenolysis. And there's a breakage of glycogen into glucose. So we get glucose from there. And if that also falls short, then the liver tries to synthesize glucose, which is a process known as gluconeogenesis. So, this gluconeogenesis, glycogenolysis is very, very important for our human body, right? Coming to the fatty acids, there are certain organs which have a high mitochondrial oxidative capacity, like, liver, skeletal muscle, heart, and renal cortex. They can use fatty acids. And we also know that these fatty acids are stored as triacylglycerols in adipose tissue. And the source, again, is the dietary lipid intake. And there's something which I said in the beginning is a de novo lipogenesis from glucose, which happens in the liver and in the adipose tissue, right? So whenever there's a glucose shortage, fatty acids actually come down to the rescue. So the fatty acids are then released from the adipose tissue by this hormone-sensitive lipase. And then there's a fatty acid oxidation, which is happening, which actually provides energy for gluconeogenesis. And these fatty acids can also be converted into ketone bodies. And we know, in contrast to fatty acids, the ketone bodies, they can actually cross blood-brain barrier and can be a source of energy for the brain. So now, so much of thing is happening, gluconeogenesis, glycogenolysis, and looking at the tissues. So all this requires what we call a very tight regulation of the metabolic pathways. Now, how do you kind of modulate these pathways? How do you quickly switch to these pathways? How do body senses that, now the glucose is less, the fatty acids have to come in? All these are taken care, are something known as transcription factors. So the transcription factors are basically nothing but they are proteins. They control the rate of your genetic information from DNA to mRNA, and they bind to a specific DNA sequence, and then they kind of, generate or they activate various genes for, the synthesis and for the switch of all these metabolic, requirements which are happening in the body. So that brings me to the final thing on this, that the PPARs, what we will talk now, and the farnesoid X receptors both belong to a family of what we call the nuclear receptors. They actually are involved in the glucose metabolism, and they actually act as the transcription factors, right? So this is how, as I said, once you have the ligands, and then this acts on the, the bioheteroderma, they activates, either the PPAR response elements or the FXR response elements, and the signals are kind of generated. And finally, then you have the effects on either fatty acid oxidation or improve in insulin sensitivity and all. So let me just show you now the data on saroglitazar. So this was the phase 2 study, which was presented in ASLD again last year, which is known as the evidence 4 study. And this study showed that the saroglitazar does improve the liver fat by, as assessed by the MRPDFF and the ALT. So I think this was a phase 2 study for the evidence 4. And then we recently, this study was presented in the Apostle. This is known as the evidences 2 study, which was a phase 3 histological based study in India, conducted in 10 centers with 102 patients. And this study actually showed a statistically significant reduction in proportion of patients in respect to the decrease in NAFLD activity score by, say, 2 points, I think, in comparison to a placebo group. And there were a lot of other, secondary endpoints. And based on this drug, as I said, has now been approved for use in patients with NASH, which are F1 to F3, for use in patients with fatty liver disease. So I think this is all which I wanted to say about the current management. I think before we go on to the emerging, and if Professor Saraswat and Professor Makaria permit me, I think we can take some questions at this stage and then move on to the emerging treatment modalities, which I will take maybe another 10 minutes or so, 10, 15 minutes.
Ajay, if you want to take questions, I think we have already piled up about close to 100 questions. People have fired in already. So I think what I could do is to start off with what I think are some of the important ones. And then depending on what the advice is from our timekeepers, probably we take 5 minutes for questions. Govind, does that sound okay?
We take 5 minutes, yes, sir. Yes, sir.
Let's take 5 minutes for questions. So I'll try to sort out of these 90 questions, and some of the interesting questions are related to diagnosis. I think important people like Shiva from Vizag, and also one of our old alumni, Vimal Saradeva, who's now in Rajkot and is practicing, is very, very inquisitive. And there are others. The basic question is that today, can we start pharmacologic therapy for NASH with these drugs that we have spoken about without liver biopsy? Because you mentioned that if you're suspecting advanced fibrosis and other situations, even the ASLD recommends liver biopsies. But in people either with suspected advanced fibrosis or otherwise, can we start pharmacologic therapy without a liver biopsy? Medico-legally, is it safe? Are some of the concerns. What are your thoughts, Sajay?
I think, that's a very pertinent or important question as far as I would say the clinical practice is concerned. And in clinical practice, I must admit that we do start these drugs without liver biopsy also for various reasons. And the major reason always is that the patients may not agree to undergo liver biopsy, number one. And if your non-invasive assessment is suggesting you that this patient has got and is likely to have, as I said, on non-invasive assessment, are likely to have significant inflammation or significant fibrosis based on your non-invasive assessment, we can take a case-to-case decision or an individual decision of starting these drugs. And then out of these, I think my experience is that we feel more comfortable with vitamin E, which is, a safer drug. And we tend to give these drugs for around 6 months, even without biopsies. And as I said, we have, after this retrospective analysis, we have also started using vitamin E, even in our high fibrosis or cirrhotics without doing liver biopsy. That is on pioglitazone vitamin E. Now we have a new molecule armamentarium in the armamentarium, which is saroglitazar. And earlier this drug saroglitazar was recommended only in patients with diabetic dyslipidemia. But now, as I said, the DCGI has approved this drug for, NASH also. So if you look at the real life data on the usage of saroglitazar, I think there's a huge data which is available in more than, I would say, 5,000 patients where people have not been subjected to liver biopsy. They have been given saroglitazar, and people have shown reduction in not only in their ALT values, but also in their CAP score based on the FibroScan, the controlled attenuation parameter, which is a marker of hepatic steatosis, and their LSM score, which is basically a marker of hepatic fibrosis. So we do have a real life data. And as I said, ICON-D, we are collecting all this real life data. So I think real life practice or clinical practice is entirely different from your academic practice or your, what the societies would recommend.
So you would say that it is reasonable under given evidence to begin pharmacologic therapy, especially with the drugs you have named where that evidence is there, without a liver biopsy. And
sure.
Legally, it should not be a problem for anybody prescribing these medicines.
Sure.
So that is...
Can I ask a question?
Go ahead. Yeah.
This is a question from gynecologists.
So gynecologists are also logged in.
Some of them, they did that. This is Suman Lal from Gurgaon, which says, ask a question, a lady with a PCOS has fatty liver,
Right.
normal enzymes. Would you prescribe vitamin E to her?
See, the PCOS is again, I think because of the time and I was focusing only on the treatment. PCOS, we know, is a disease which is again associated with insulin resistance, right? And I think there's a good data which is available about treating fatty liver disease in ladies or in women with PCOS with insulin sensitizing drugs. And the most often the drug which is used in these women is metformin. Right. So I would suggest that I think if they're otherwise using, or if they have fatty liver disease, and if you want to use, I think metformin would be maybe a first line drug. But then if he or she, in PCOS, if she qualifies for vitamin E, right, I think based on your non-invasive assessment, and even if she has PCOS, I think vitamin E can also be given.
Okay, I think another interesting question has come from Dr. S.K. Sharma, New Delhi, and he says that many patients with fatty liver have also got metabolic syndrome and are on beta blockers. You have given certain recommendations about exercise, how you calculate the maximal heart rate. So should they exercise? How much exercise? What heart rate should they target when they are beta blockaded? Practically important questions. What do you think, Ajay?
I know it's an important question, but a difficult question for me to answer. I think as I said, again, fatty liver disease is a part and parcel, or what we call a hepatic component of metabolic syndrome. So it's not only hypertension. I mean, they have so many other comorbidities, and I think they could be on so many other drugs, could be statins, could be beta blockers, could be aspirin, or so many other things. And for them, how much to exercise, I think, again, if you look at our position paper, we're given very clear-cut recommendations that a cardiology evaluation or evaluation by cardiologists in that scenario would be very, very important before you, I think, take our advice, which we actually give for their point of view.
Right. So heart rate may not help you in deciding the endpoint of exercise. People, and they may be having limited exercise tolerance.
Sure.
So banking on exercise in this group may be a bit of a problem. Right. About drug therapy. Before we go on to drug therapy, there was a set of questions from different people about differentiating alcoholic hepatitis from non-alcoholic fatty liver disease, particularly in people who do consume alcohol. In fact, one questioner, I've not been able to note the name, has asked, what is the evidence on the basis of which you are restricting alcohol in non-alcoholic fatty liver disease, and things to that extent. So there is a common problem. Maybe you could quickly address that, Ajay.
Yeah, I think two things. One is, as I said, I think in clinical practice, I think, and this happens very often in our clinical practice in this part of the country, in Punjab and Chandigarh, where I think we do see people who are obese, diabetic, and full-blown metabolic syndrome, and also consuming alcohol, right? And either in insignificant amount or in significant amount. So this combination is a real problem. But if you look at the society guidelines, or for that matter, any guidelines, patients with NAFLD, if they ask you a question, whether they can take alcohol or not, the answer would be, for heavy drinking is a big no. Now, nobody talks about the mild or moderate drinking, and how do you define that, again, would be a big question, because there was some data which was initially published that some amount of a special wine could even be helpful for fatty liver disease. But then if you ask me in clinical practice, most of the patients, actually what we see NAFLD are actually kind of non-drinkers or teetotalers. But then even if they are taking socially, I think we tell them, we kind of discourage them for taking, alcohol, number one. The second is about the differentiation between the ASH and NASH. I think there are two things which are very important here. One is obviously the history. Second is, you look at in NAFLD, it is, if the enzymes are elevated, it's the ALT which is more than AST, or they are side by side. But if it's an ASH, the AST will be higher than ALT number 2. And I think the other thing which I would like to tell here is, again, very important for the residents would be that they should go on to the Mayo Clinic site. And the Mayo Clinic people have given a score. This is known as an ANI score. ANI is alcoholic hepatitis and non-alcoholic hepatitis index. And there they put in, the OTG level, diabetic status, AST, ALT, and all, give you a very score. and it has a very good accuracy in telling you whether you have ASH or NASH. So, and then there are other ways. You look at the MCV, you look at other things, I think, on which basis you can differentiate.
We can go now to the other part of your talk.
Okay. How much time do I have?
As little as you can, but...
So can you give me 10, 12 minutes or 15 minutes?
That's also 10 minutes.
Well, it's 12:53 now, so maybe 10 minutes if you can try.
Okay. I'll finish in 10 minutes. Okay. So as I said, I think the emerging modalities again can be divided into two, which are we do have certain available drugs in the market in India and elsewhere, but they are not approved for NASH. So we would need some more data on that, and I have put this also into emerging treatment. And there are certain drugs which are still in clinical trials, right? So I'll briefly tell you, for example, metformin, as I said, is not approved for NASH. But the same group, the Nagachalasani group, actually has come up again with this retrospective analysis, which is again published last year, with the use of metformin in, again, cirrhosis and high fibrosis. And they have again shown that the patients, those who are metformin users, they had a lower risk of overall mortality, or for that matter, even transplant, and lower risk of HCC. So I think metformin, I personally feel, is a very good drug, which actually needs more evaluation, both in non-cirrhotics and in cirrhotics. But I put it as an emerging drug, and I think we need more data. There are a lot of anti-diabetic drugs which are being evaluated, and one of them is the liraglutide, and this was one study which was again published 4 years back, so-called the LEAN trial, which actually showed improvement in NAS score. But as I said, we still need more data on this. Available drug, not recommended. And other than the liraglutide, this is GLP-1 analog. I think the semaglutide is another drug which is coming up now, and the data is still building on that, but we will need some more data on that. Probiotics, again, this was our work which we published last year. Again, I think more data is required, but as a proof of concept study, we showed that the probiotics, because of the role of the gut microbiota and the bacterial overgrowth in patients with fatty liver disease, may have some role. And for that matter, I think it would be true even for the FMT, the fecal, microbiota transplantation, for which again the trials are still on for fatty liver disease. So I'm not going into the modulation of gut microbiota is another one. So now let me come on to the residents about the ongoing clinical trials in patients with the NASH. And for this, I think if you are appearing for the exam and if you are asked for the kinds of clinical trials, I think you may also be asked that what are phase 2 trials, what are phase 2A trials, phase 2B trials, what are phase 3 trials, because ultimately it is very difficult to remember the names of all the drugs with the large battery which are being tested in patients with NASH. So for the case of simplicity, I would suggest the residents to remember that these are the drugs which are in phase 2 and these are the drugs in phase 3. And, and this is also possible that the drugs which are being tested in phase 2, and if they are found effective, only then they will go to phase 3. But, and in phase 3, they may or may not be effective. That's very important. And if the phase 2 find that they are not effective, obviously they will not go into phase 3. So what is phase 2? As I said, phase 3, which drugs are in phase 2, phase 3? I think it is very important for you to understand that, number one. Second thing, which again, as I said, it is very difficult for you to remember all the names. What you should remember is the site of action of these drugs. So the drugs have been divided into 3 categories. One are the drugs which are known as the metabolic drugs, or they act at the metabolic pathways, whether they are insulin sensitizers, they improve insulin sensitivity, or they reduce the liver fat, like, as I said, PPAR agonist here, Aramcol here, right? Or ACC inhibitors, will come down to that. Or they could be trying to decrease the inflammation, so what we call the anti-inflammatory drugs. Or they could be trying to reduce the fibrosis, they are known as antifibrotic drugs. So I think you should try to, remember this, that which drugs, the FXR are metabolic drugs, PPAR are metabolic, right? Your chemokine inhibitors are anti-inflammatory, but also anti-fibrotic. Your apoptosis inhibitor, ASK1 inhibitors, they are, anti-inflammatory, right? So I think this is easier to remember that, I mean, which are the pathways they are basically kind of acting on. Now, let me again tell you data on some of these drugs, which are, as I said, could be phase 2, phase 3, failed in this. So this is one drug from Genfit, and we talk about saroglitazar, which is a PPAR alpha and a gamma dual agonist. There's another dual PPAR agonist, which is PPAR alpha and delta. And this is known as elafibranor. And this elafibranor study from multi-center study was published again around 4 years back. And this was a phase 2 study, which on, the analysis by a redefined definition found it to be better than the placebo with resolution of NASH without worsening of fibrosis. And based on this phase 2 data, I think there is a ongoing phase 3 study, which probably you just can remember is a Resolve It trial, because the phase 2 data had shown the efficacy of 120 milligram of elafibranor. So now they are recruiting a large number of patients. So this is how the phase 3 trials are different from phase 2. You have a large number of patients, so it's around 2,000 here. And then you have a longer follow-up, maybe 1 year or so. And they have already done the interim analysis at, they plan to do interim analysis at 18 months. So you can do that, right? So you can remember this drug. The other category of drugs, which again belong to the metabolic pathway targeting, are the, as I said, the farnesoid X receptor agonists. And as I said, these are the nuclear receptors, and they act as the transcription factors, which I tried to explain you earlier. So one of the drug which is FXR agonist is from the Intercept, and this is known as obeticholic acid, or in short, we call it as OCA. And the synthetic, this is synthetic ligand for the FXR receptors, but the natural ligand is the CDCA, but the OCA is around 100 times more potent than, CDCA or the quinodeoxycholic acid. And the FXR agonists have been shown not only to have role in the bile acid metabolism, but also to lower the hepatic triglyceride content, improve the insulin sensitivity, and hyperglycemia. So based on this, again, 5 years back, this was a phase 2 data, which was published. This was known as a Flint-2 study, where they showed that the OCA25 was better than placebo in no worsening of fibrosis and in decreasing the NAS score of more than 2 or more than 2 points. And based on this, there was a phase 3 study which was initiated, and this was known as a Regenerate trial. And the interim data of Regenerate trial was presented last year in EASL, and they showed that the OCA, which is 10 milligram and 25 milligram, and the primary endpoint, which is the fibrosis improvement by more than one stage without worsening of fibrosis, was better in OCA in comparison to the placebo. So based on this, now the company has actually filed for the approval of this drug to US FDA and also to the European authority. And before this, COVID pandemic, it was thought that there is a possibility that this OCA may be approved in the middle of this year for the treatment of, NASH. The other drug is, as I said, is a chemokine inhibitor, which is a sinicriviroc. And the phase 2 data again was published 2 years back. And this was known as a Centaur trial. And this Centaur trial actually showed that the CVC was not only safe and well tolerated, but it does not improve the steatohepatitis, but there was a clinically some modest impact on the fibrosis. So based on this, there is again a phase 3 study which is going on, and which is known as an Aurora study. And they are again recruiting a large number of patients in this molecule called sinicriviroc, which is, as I said, is a chemokine 3 and chemokine 5 inhibitor, category of anti-inflammatory, but also has an anti-fibrotic drug. Then there are 2 drugs which are, again, that I would say anti-apoptotic drugs. And one of them is the, apoptosis also plays a major role in the pathogenesis of fatty liver disease. One of these drugs is a oral pan-caspase inhibitor, amdicasin. And this data was presented again last year, November 19, on the use of amdicasin in patients with NASH with F1 to F3 fibrosis, and this was a negative study, which showed that the amikacin, despite the the primary endpoint of fibrosis improvement was not met, and similar findings were observed for NASH resolution. So which means this was a negative study. Another anti-apoptotic molecule which actually came as a big bang was a selonsertib. This is a molecule from Gilead, and this is an apoptosis signal kinase 1 inhibitor, what we call the ASK1 inhibitor. And again, this phase 2 data was published in 2018 in Hepatology, and this actually showed it to be effective in improving, not only fat, but also fibrosis based on non-invasive assessment like MR-PDFF and MR elastography, and also an MR biopsy, but the number here was small. This was 72. So based on this, as I said, they found it to be effective. Based on this, the Gilead then started 2 very large clinical trials. And these clinical trials were called as Stellar 3 and Stellar 4. And these 2 studies, basically, Stellar 3 was for the patients, those who had, up to F3 fibrosis. And for F4 fibrosis, which is compensated cirrhosis, this was Stellar 4. But unfortunately, both these trials, Stellar 3 and 4, also turned out to be negative and were prematurely, terminated. And so the selonsertib as a drug is also kind of out. Now, since there's a problem, and I think the NASH is a difficult disease, I would say, to control or to resolve as far as the pharmacotherapy is concerned. So then came the concept that the individual drugs, if they are not working, can we combine the drugs? And again, the Gilead came with this, another clinical trial, which again, the data has been recently shared, the results. So, this is a molecule called the forsocostat, which was the Gilead molecule GS976. So this is an ACC inhibitor. So what is ACC? ACC is an acetyl-CoA carboxylase enzyme. So what does it do? This is basically an enzyme which basically acts as a rate-limiting enzyme for the conversion of acetyl-CoA to malonyl-CoA. And that is how, the fat is synthesized. So if you stop or break this or inhibit this enzyme, ACC, by the ACC inhibitor, the acetyl-CoA is not converted into malonyl-CoA, and that is how the lipid synthesis would go down. So that is the ACC inhibitor, forsocostat. So what they did, they combined this forsocostat with cilofexor. Cilofexor is an FXR agonist, different from the OCA. And they combined it with the selonsertib, which I said was a ASK1 inhibitor. So they have 3 molecules combined together. And the entry points for patients with bridging fibrosis and compensated cirrhosis, and this was known as the ATLAS trial. But then, unfortunately, we have had the data on this is also available, and this is also a negative study. So even the combination of these drugs has not been found to be effective in improving fibrosis in patients with bridging fibrosis and compensated cirrhosis related to NASH. So I think I'll summarize now what I said, and I think then we can take some questions. So as I said in last maybe this 40-50 minutes is that if you have a patient with fatty liver disease, NAFLD, try to categorize them whether they have NAFL or they have NASH or they have NASH cirrhosis or they have HCC. I have not purposefully discussed about the treatment of cirrhotics and HCC which are related to NASH. I think this is beyond the scope of this lecture, and I have predominantly focused on the NAFL, NASH, and maybe NASH with some high fibrosis. And once you have categorized and once you have classified these patients based on your non-invasive assessment or on biopsy, whatever you have done, as far as the treatment is concerned, you have to advise exercise for everybody. And I told you what kind of exercise, how long, how many days a week, and how much. This I have already told you. And if the patients are overweight or obese, weight reduction is must. And I also showed you data that with lifestyle modifications, if you are able to achieve the desired body weight, you do get improvement in your inflammation and fibrosis. But the problem, as I said, is that it is difficult to achieve and maybe difficult to sustain. Finally, if you're using drugs, I think now we have 3 drugs which are at least available in India. One, obviously 2 were the vitamin E and the pioglitazone, which are recommended, as I said, for biopsy-proven NASH. But we did discuss that if given, in a particular patient, even if the biopsy is not possible, you can take a decision for that. The new drug which has come in, which is available now in India, approved by the DCGI for treatment with NASH, again for F1 to F3 fibrosis, not for cirrhotics, is saroglitazar, which is, as I said, is a PPAR alpha and a gamma agonist. We also need to understand that fatty liver disease, as I said, is emerging as a multi-system disease. You can have cardiac involvement, you could be diabetic, you are more prone to have diabetes, hypertensive, you could have chronic kidney disease, malignancy, osteoporosis. I think so. You have to see the patient in totality. Don't only focus on liver. I think you have to take care of all other systems, which is very, very important. Finally, the emerging treatment I divided into 2. The drugs which are available but not yet approved. I showed you some data on metformin. I did show you data on semaglutide. I didn't show you data on SGLT inhibitors, which are other drugs which are used for diabetics, and there's some data which says that they do improve fat. I also didn't show you data on vitamin D. Again, some meta-analysis saying that it could be helpful. I did show you our own data on the use of probiotic in patients with NASH as a proof of concept study. As far as the drugs which are in clinical trials, as I showed you, there are a lot of drugs in clinical trials, and in a short time, it is really not possible for me to cover all these drugs. But I gave you the concept that you should know, that you must remember that what phase of particular clinical trial that particular drug is. You must say, is it a phase 2 study or a phase 3 study? You should also look at that drug, where does it act? Whether it acts on the metabolic pathways, whether it is an anti-inflammatory drug or it is an anti-fibrotic drug. The drug which may sooner be approved, and we hope that it gets, which is the obeticholic acid. But obeticholic acid also is not free of, issues and the side effects like pruritus and hypertriglyceridemia. And people are now calling it as the interferon of NASH, like you have had in hepatitis C. So we can discuss this more on this. And lastly, as I said, people are not trying, because it's so difficult disease to tackle, people are not trying the combinations of various drugs, and we need to have more data on these combinations. Thank you very much. And again, I think my sincere thanks to the ISG, Professor Govind, Professor Saraswat, and I'll be happy to take any questions.
Okay, I think Ajay, as expected, a masterly exposition and coverage of a very vast area with a lot of issues, and very succinct and clear answers were provided. But I think as at last count, we are flooded with over 250 questions. So now, depending on Professor Makharia's signals, how long we can go on, we'll start with some of the more important ones. A lot of people, I think there must be at least a dozen or more people from different parts of the country, including Dr. G.K. Pati from Hyderabad, Vineet Tomar from Hyderabad, P.K. Reddy from Chennai, Dr. Subhash Agarwal from Surat, want to know what is the current status of ursodeoxycholic acid in the management of NASH, because it is one of the molecules you haven't, most of us don't talk about it much, but it is definitely extensively used in the country. So in evidence-based, currently, what would be your recommendation and comments on urso?
I think ursodeoxycholic acid has a long story in fatty liver disease. And if you look at the earlier studies, I think it did show that the biochemical improvement does occur with ursodeoxycholic acid, which is the ALT improvement. The problem happened when many years back, a placebo-controlled trial was published in Hepatology, which actually showed that the ursodeoxycholic acid was no better than placebo in causing the histological improvement in patients with NASH. So that is how it actually took a backseat. But then another concept came in, and that was the use of high dose ursodeoxycholic acid. And in that direction also, if I can recall, there were 2 studies which were conducted with a high dose ursodeoxy as high as maybe 25 milligram per kg. And I think those studies also were not didn't show it to be very effective. So based on that, if you look at the recommendations from most of the societies, whether this is our Indian societies or the European or the American societies, they will not recommend ursodeoxycholic acid for the treatment of NASH. But again, coming to the clinical practice, and I must admit that we do use this drug in our clinical practice. So, I mean, there are patients, those who do not fit into your so-called NASH on a non-invasive assessment, right? And they may have slight elevation of liver enzymes. And if you just give them lifestyle modifications, I think the patients usually are not kind of satisfied. Whether you call it as a placebo effect or whatever, we tend to use ursodeoxycholic acid in this subgroup of patients, those who do not fit into NASH non-invasively, and you have to give them some drug. I think we do use this in clinical practice. And to tell you the truth, we do see biochemical improvement in these patients. But the problem, as I said, is that there's no histological data on this.
Right. So probably it is one of those drugs that we used a lot when there weren't many drugs around. It does have some benefit biochemically, but not histologically. Evidence does not show histologic advantage. So as better drugs come along, we should probably be thinking of phasing out the use of urso by and by. Would you agree with that?
I agree, sir.
Right. Seroglitazar has evoked a lot of interest and enthusiasm, and there must be at least about 20-25 questions on different aspects of seroglitazar. So I'll try and cover a few of them one by one. People have already been using seroglitazar in the context of fatty liver, whether in diabetics or otherwise. So interesting question is from Dr. Ravi Thakur in Varanasi, who says that after starting seroglitazar, once there is an improvement in transaminases, but a rebound increase in transaminases is noted when it is discontinued. So what should be the duration of therapy and what should be endpoints when we start seroglitazar?
I think I agree with him, and this is not peculiar to seroglitazar. This is peculiar to all pharmacological therapy which are used in patients with NASH. As long as you keep giving pharmacotherapy, the enzymes would settle down, and as I said, they may improve your histology. But the moment you stop the drugs, I think the disease would come back, the enzymes would come back, and the histological worsening may also happen. So I think that's a learning point, that this is a metabolic disease. This is a part and parcel of metabolic syndrome. I think alone with pharmacotherapy, or more than that, I think we have to take care of our risk factors. We have to continue to apply lifestyle modifications, and pharmacotherapy is not the answer. Pharmacotherapy is answer only in a subgroup of patients, those I would say personally, those who have advanced disease, those who have high fibrosis and you want to reduce the extent of fibrosis, those who they have high inflammation, you want to reduce the inflammation, which means that you don't want them to progress on to cirrhosis. I mean, this is the aim in any liver disease, whether it's Hep B or Hep C. Your ultimate aim is that they should not progress on to, cirrhosis. So if that is the high risk group, and that is where this drug is actually recommended, so whether it's seroglitazar or it's any drug. So if you ask me the duration, the trial phase 3, which we did in India for 102 patients, and the results which are presented in a parcel, and based on which the DCJ has given approval, this drug was given for 1 year. So if you have to use seroglitazar in a patient with NASH, I would say 1 year. But then, as I said, don't forget the lifestyle modifications. Drug is just, a short kind of an arrangement, I would say, I think, or to reduce the inflammation or the fibrosis, but ultimately it is the lifestyle interventions.
Right. So what you're saying is at least 1 year, but at the end of the 1 year, things have got to have normalized or come under control for you to considering stopping it. If, as in a diabetic patient, you get euglycemia, you get normal HbA1c, but you discontinue and things slip back again. So if the basic processes have not been checked, weight loss hasn't been achieved, and then chances are that you may have to continue it for a longer duration.
Yeah, but we need to have more data on that.
We need more data are required.
Yeah,
sure. You're recommending based on current data.
Yeah.
The other important question is related to Dr. Kundan Kumar from Jamshedpur. His question is that now that we have seroglitazar, pioglitazone you spoke about, and vitamin E today, how should you be using them, in what order or in priority? And Dr. Ashish Gupta has a similar question from Noida. He says, what do you think about combining the three, vitamin E, pioglitazone, and seroglitazar? You already talked of combinations with newer drugs. How about combining older drugs?
So I'll take the last question first. I think it's a very good idea. So I think I would call it as an Indian jugaad. So I think maybe we have 3 drugs available, and let's do a clinical trial where we combine vitamin E, pioglitazone, and seroglitazar, and see if I think this does wonders. I think good idea. But then coming to the order by which we should be using, as I said, in our clinical practice, we have hardly been using pioglitazone because of the issues which I said, predominantly the weight gain, pedal edema, and the cardiac issues. So our experience predominantly, largely till date, has been with vitamin E in clinical practice. But then now with the coming in of seroglitazar, and I think it's a safe drug. There were no side effects, which were major side effects, which were reported. So I think we can choose either of the two, either seroglitazar or vitamin E, and you can even divide. I think the trial on sero, the entry point was not diabetic dyslipidemia. So even if you don't have diabetic dyslipidemia, you can still choose, seroglitazar. But then if there's diabetic dyslipidemia, I think sero should be given the preference. And if there's no diabetic dyslipidemia, it could be either of the two. That would be my answer.
Right. Okay. Another similar question on the same lines comes from Dr. Sanjay Saxena in Dehradun. Many people who are already on statins, now that seroglitazar is available, and can we combine seroglitazar, statins, or should we consider discontinuing statins if seroglitazar are used? What would you say?
Again, I think difficult question, but then we know that the seroglitazar does have effect on dyslipidemia. So you have to probably individualize, patient. There is if you're using statins for dyslipidemia and now you start using seroglitazar, I think depending upon how your lipid profile stays, you can take off maybe statins. Yeah.
Finally, a quick question on indications. Lawrence Peter from Bangalore asks whether seroglitazar has been used for PCOS, for polycystic ovarian syndrome. And another question is regarding a seroglitazar for lean NASH. Would you consider it for lean NASH? This comes from Dr. Zoeb in Nagpur. What do you think?
So 2 questions. So the PCOS, I think again, let me say here, the manufacturers of the seroglitazar were very keen to do this clinical study where they were trying to include patients with PCOS, with fatty liver, and the usage of seroglitazar in them. But then somehow, finally, they landed up doing a study where the fatty liver disease was kind of taken off. So they are using this drug, and if I'm right, there could be this study which is going on where they're looking at the efficacy of seroglitazar in PCOS minus the fatty liver disease. Earlier was fatty liver disease, as I said. So it's a minus the fatty liver disease. So I'm not aware of the results on that, number one. And what was the second question? On the lean NASH. So again, I think if you look at the data, so see, if you have NASH, whether you are lean or whether you are obese, doesn't really matter if you're using the pharmacotherapy. If your biopsy is showing you that you have F2 fibrosis, you have inflammation, and you fit into the definition of NASH, I think you can very well use seroglitazar there also.
Right. Finally, about a last thing on seroglitazar was concern with its side effect profile. One question from Dr. Rakesh in Trivandrum was, have you seen thrombocytopenia on seroglitazar? And the other was, is there an increased myocardial infarction risk or any cardiac risk related to seroglitazar reported in studies? And in general, what are the side effects to beware of when you use sero?
I think, again, I will come down to the data on that. 102 patients, which was again presented. In that particular study, which is the phase 3 data, in that particular study, there were no cardiac events, myocardial infarction or any other. or thrombocytopenia, significant thrombocytopenia, which was reported. Real life, again, there's a huge data, as I said, on more than 5,000 patients. Again, I think in that, if I remember right, I think the cardiac issues were not the major issues with saroglitazar. So I don't think, largely it's a safe drug. I mean, some of our patients did complain of some, minor side effects like the fatigability, headache, or GI symptoms, but no major issues which we encountered with saroglitazar.
Right.
Saraswat, we will have now limited time. We are 1:22 already. So can I ask you two small questions which are there again from the meeting of the audience? Number one, that Ajay, if you treat a patient with NASH, how long do you treat? How many months? How many years?
No. This is a lifelong disease. It's like diabetes. So it's a metabolic disease. There is no duration. The duration we are talking is only about the duration of pharmacotherapy. I mean, I tell you, in our clinical practice, once we see an ecogenic liver on ultrasound, I think it's very difficult to get rid of that ecogenicity from ultrasound, right? So whatever you may do. So like you say, once hepatitis B, always hepatitis B. So same, I've started believing that it's very difficult to get rid of maybe fat from the liver. And even if you do that, even if you're able to do that, which is obviously possible with lifestyle interventions and pharmacotherapy, your treatment, which is nothing but lifestyle interventions, have to continue for long or maybe lifelong. If people, there's a good data to say that, and there's a data from the PIVEN study which have shown that if you stop pharmacotherapy and if you tend to gain weight, you tend to, become obese and diabetic, your liver disease may kind of progress.
I think the question is, how long do you, if you start a NASH patient with any of the drug which you described?
So that I've already said.
How long do you give this drug? No, the lifelong will continue. But how long do you continue your drugs? How long do you?
Yeah, see, the data on the vitamin E and pioglitazone was for 96 weeks. So that was the trial PIVENS, they said 96 weeks, right? But then in clinical practice, when we use vitamin E, we don't give it for more than 6 months. Number one, that is. And saroglitazar, as I said, 1 year.
The second question is, I believe is a very important question. Again, this is the question on which Dr. Suman had asked, that do you alcoholics have support group? Non-alcoholic treatment is just physical activity, more of so you're giving about treatment in the patient's hand. This is what we call it increasing the involvement of patient by creating support groups. So what is your opinion about creating support group for those patients who have a fatty liver disease?
I absolutely agree. And I think very recently, last week only, I was trying to answer a survey, a global survey on NAFLD policy, which was shared with us from the EASL. And they were actually asking us this question, that do you have any support groups in the country? Do you have any social groups? And I actually had to say, and then we had a core committee and I spoke to different people. Professor S.P. Singh told me that they have a Kalinga Liver Foundation. They do work for the care of their patients with fatty liver disease.
You do believe that we should create?
Yes, I do believe. Absolutely.
People, and we are the people, all the doctors or the gastroenterologists who are working, who can we can increase awareness among patients to create support group, and therefore among themselves they chat together and get treated that way. We believe that's very important.
Yeah, I was coming to that, and then in the same survey they also asked us about any strategies from the government on the liver health or on nutrition, which are there in written, or do you have as social groups? And we don't have any. And I absolutely agree that all these things have to start from the primary school education. We need to tell them about the healthy lifestyle, healthy diet, and this epidemic, can be controlled only by prevention rather than by these drugs which we talk today.
Yeah. You think this is worse than corona?
So I don't know whether you say if fatty liver and corona is a subject by itself. Let me say that today evening we have another webinar. So if people are interested in listening to corona and NAFLD, we can discuss there.
Dr. Saraswat, do we close now with your permission?
Yeah. Yeah, absolutely. I think one very crisp and a very quick question that Ajay has to answer is from Professor Jang Dilavri in Chandigarh.
Oh, yeah.
No. Can you accept phase 3 trial data published in abstract without peer review, which is happening with some of the more recently produced drugs, and people are rushing in to use them? What do you think?
I agree. I think this is still not published as a full paper. But then I don't know, I mean, what data was, given to the authorities and what data was presented. So obviously this was not only the phase 2 and the phase 3 data which was presented and the real life data. I think probably the results or the decision is probably based on that.
Right. Okay, Govind, I think here we must now thank Dr. Ajay for an excellent session, for a very good coverage of a vast area in a very precise and detailed manner. And I think we will have a list of about 350 questions, of which we've been able to take up probably about not more than 30 questions. So maybe at some point when you're free from your hectic webinaring, you can think of answering some of these questions with the help of the ISG Secretariat.
Sure,
Many of
sure.
obviously repeat questions.
Would you suppose we send you these questions?
Yeah, you can mail me the questions and I will try to answer. Yeah, as many.
Then what we'll say, we do all these questions and their answers we'll put on the website, which is ISG Masterclass website.
Right.
And there one can log on to see all these questions. Thank you, Ajay, very much for a wonderful talk. And thank you everyone for joining this webinar. Let me remind you that we have a next webinar scheduled on April 22nd. And this again, we believe is a very important topic. That how do we approach a patient who is found to have a SO in the pancreas? And is a bit difficult and challenging topic, and for which we have invited Dr. Surinder Rana from Chandigarh to speak to you on this Wednesday from 5 to 6. Thank you, Dr. Saraswat. Thank you, Dr. Ajay, for the wonderful. Thank you, everyone. Thank you, Yogita, and thank you, everyone, for this.
Thanks, Govind. Thanks, sir. I think bye-bye. Thank you very much.
Have a nice Sunday.
Thank you. Bye-bye.